Hello everyone, we are talking about cardiac septation. This is the fifth section of this lecture in which we'll talk about the ventricles. This section has been further subdivided into septation of ventricles, that is how partition of ventricles take place, how a common ventricle is divided into two adult ventricles which form the pumping machines of the heart. We'll talk about the semilunar valves which guard the outflow tracts of the ventricles, and finally we'll talk about the clinical correlates as what might go wrong and what are the consequences of if the things may go wrong. So now let's get into the septation of ventricles. Septation is the partition of ventricle. Now the time frame is the end of fourth week of development. The primitive ventricles now they begin to expand. So these are the primitive ventricles. They now begin to expand. There's continuous growth of myocardium on the outside. So myocardium continues to grow on the outside. At the same time, there's continuous diverticulation and trabecular formation. So there's diverticulation and trabecular formation, projections formation from the inside, as a result of which the medial walls, these are the medial walls of the ventricles, they fuse with each other and form the muscular interventricular septum. So how is the muscular interventricular septum formed? It is formed by the fusion of the muscular walls of the expanding ventricles. So if they do not merge completely, a deep apical cleft may be formed between the two ventricles. The free communication between the two ventricles occurs through the cleft between the muscular interventricular septum. This is the muscular interventricular septum and the endocardial cushions. These are the endocardial cushions, these are the endocardial cushions, and this is the muscular interventricular septum, and the free communication is occurring place between the cleft which is left between the interventricular septum and the endocardial cushions. So this is the interventricular foramen. It shrinks on the completion of conus cordis. So this interventricular septum has completely shrunk on the completion of conus septum. Now it is closed by outgrowth of endocardial cushion from the top of the muscular interventricular septum. So tissue from the top of this muscular interventricular septum goes on to close off this interventricular foramen. Now this tissue fuses with the abutting parts of the conus septum. Obviously these are the abutting parts of the conus septum, and this tissue now fuses with the abutting parts of the conus septum so that it can completely wall off the ventricles. Complete closure in the interventricular foramen forms the membranous part of the interventricular septum, and this is now the membranous part of the interventricular septum. So interventricular septum has two parts, a muscular part and a membranous part. A muscular part is formed by the medial walls of the growing ventricles. However, the membranous part is formed by the endocardial cushion at the tip of the muscular part, which tend to close the interventricular foramen by uniting or abutting with the conus septum. Now let's talk about the semilunar valves. Semi means half, lunar means moon. So these are called half moon valves, or valves that look like half moons. There are two semilunar valves in the body, the aortic valve and the pulmonary valve. So the partition of truncus arteriosus is almost complete. Obviously, the truncus arteriosus has already been formed. So the two segments, segments of the outflow tract, that is the aortic segment and the pulmonary segment, have already been formed. The primordia of the semilunar valves become visible as small tubercles on the main truncus swellings. So these are the adult already formed heart, but in a developing heart, we see small tubercles which are visible as on the main truncal swellings, which are the primordia of the semilunar valves. A third truncal swelling then appears in both the channels which are found opposite to the fused truncal swellings. So initially 2 truncal swellings appear which are visible on the main truncal swellings. Then a third truncal swelling appears in both the channel which is opposite to the fused truncal swellings. So neural crest cells also contribute to the formation of these folds. These are the adult semilunar valves. You can see they have 3 valvular structures or 3 semilunar half moon-like structures, hence the name semilunar valves. So let's talk about the ventricular septal defects. These are very important defects. The defect in the membranous component is way more important as compared to defect in the muscular component. The incidence of ventricular septal defects is 12 per 10,000 live births. 80% of them occur in the muscular region, hence they are not very important as they can resolve as the child grows. The membranous ventricular septal defects are associated with abnormalities in the conotruncal partitioning. We talked about this before. The membranous portion of the ventricular septum is formed by the endocardial cushion tissue that lies on the top of the muscular septum and that goes on to close the interventricular foramen so that it can abut with the conal septum. However, if the conal septum is truncus arteriosus or conus cordis septum is faulty, it cannot abut with the conal septum, as a result of which a membranous ventricular septal defect may be seen. So, blood carried by the pulmonary artery may be 1.2 to 1.7 times as abundant as that carried by the aorta in case of a ventral septal defect. Here in the figure you can see this is the normal heart and this is a ventricular septal defect that tends to appear in the muscular region of the ventricular septum. So let's talk about DiGeorge sequence. DiGeorge sequence is caused by 22q11 deletion. It is also known as 22q11 deletion syndrome. It's a pattern of malformations which have their origin in abnormal neural crest cells development. So there's an abnormality in the neural crest cell development, as a result of which a specific pattern of of these malformations can be seen. So the patients have facial defects. As you can see in the figure, the patient has a tubular nose and a very specific type of mouth. This tubular nose is characteristic of DiGeorge syndrome. They have thymic hyperplasia, so the thymus has not been formed properly. We have parathyroid dysfunction in these patients, and they can also have cardiac defects which affect the outflow tracts. Moving on, we have valvular stenosis. Stenosis is tightening of a valve, as it can be seen in this figure. Here the valve has been tightened. So let's see what happens with valvular stenosis. The semilunar valves are fused for a variable distance. So the semilunar valves, which are the valves that line the aortic and the pulmonary tracts, they are fused for a variable distance. Its incidence is about 3 to 4 times per 10,000 live births. The patent oval foramen is the only outlet for the right side of the heart, obviously, because the valve has been fused, as a result of which blood cannot move out from there. So patent oval foramen is the only outlet from which the blood can exit the right side. So ductus arteriosus is always patent, obvious. So talking further, we see if this fusion of thickened valve may be so complete that only a pinhole may remain. So the valve may be fused so tightly that only a pinhole between the valves may remain. The aortic valvular atresia, here you can see in the figure, occurs when the fusion of aortic valve is complete. So the aortic valve has been completely fused. So this may lead to aortic valvular atresia. The aorta and the left atrium and ventricles are markedly underdeveloped, as a result of which the aorta, the left atrium, and maybe the left ventricle may be markedly underdeveloped. It is usually associated with patent ductus arteriosus. This patent ductus arteriosus delivers the blood to the aorta. So, now talking about the ectopia cordis. Ectopia cordis is a condition in which the heart lies outside the chest cavity. It occurs due to the failure of the closure of the lateral body wall folds, and if this failure of closure of the lateral body wall folds occurs in the thoracic region. So as I mentioned earlier, the heart lies outside the body cavity. Here you can see the heart is lying outside the body cavity. So it can occur as a part of canthal pentology. It can occur individually or as a part of canthal pentology. The defect in canthal pentology, the defect may extend from the caudal end of the sternum and extend into the upper abdomen. So in canthal pentology, the defect extends from the caudal part of the sternum and to the upper abdomen. Let's take a look at the canthal pentology. In canthal pentology, we have ectopia cordis. Ectopia cordis is the heart lying outside the chest wall. Then we have defects in the anterior region of diaphragm. Obviously, the limb buds did not form properly, so the diaphragm could not form. There may be absence of diaphragm, all right. And then we have defects in the sternum. There can be sternal defects as well. And finally, we can have abdominal wall defects, which include the omphalocele and gastroschisis. These are two defects that occur due to defect in the closure of the lateral body wall folds in the abdominal region. So this was all about this lecture. I hope you enjoyed the clinical correlates of this lecture, as they are very important and can be a part of your exams. The ventricular septal defects are important in the sense that they can correct themselves if they're present in the muscular septum. Most of them can correct themselves. However, when present in the membranous septum, they are a cause for alarm, and the patient should be checked completely for chromosomal abnormalities as well. So keep that in mind. For further lectures, keep watching sqadia.com.